So my name is Melina Honjo. I am a physician assistant that specializes in dermatology. And so I created a course for the primary care provider because they see dermatologic cases all the time, and having some exposure during training can be very useful. So I'm going to do clinical case study today, and during this time we're going to have you students work in groups of 4 to 5, and in these groups you will be asked to answer questions or discuss concepts briefly that you are going to encounter during this case presentation. And you will use a clicker device to choose the answer that you believe to be the correct answer based on the answer choices provided in the patient history. So following the case study, I will expect you to be able to recognize some common dermatologic conditions and disorders based on presentation. You will be able to take appropriate dermatologic history using active listening and summarization. And you'll be able to formulate differential diagnoses for common dermatologic conditions based on the appropriate history and images. So let's check your clicker now. So let's answer this question. What is your favorite food? If your favorite food isn't listed, choose your second favorite or third favorite. I'll give you a second to decide. Okay, so the most popular choice amongst the students this morning is taco. Okay, so let's move on to the case. So this case, a 19-year-old college student who presents to your clinic complaining of a very pruritic, remember pruritic is itchy, rash on both hands that has been causing her difficulty sleeping at least for the last 2 weeks. She has been applying over-the-counter cortisone cream without significant improvement. She denies any other symptoms and has no significant past medical history or drug allergies. She uses no other medication. So you suspect based on this very limited history that she has an eczematous rash. So eczematous rash is kind of a grab bag term for any red scaly rash, and there are many disorders that can present as a red scaly rash. So when you examine this patient's hands, you notice weeping, crusting lesions, and the hands and the fingers and widespread erythemas. So remember, erythemas redness, and there are a few scattered vesicles, blisters, and also some swollen papules, which are just red, swollen bumps. And so this is what the image of the hands look like. So you can see here there's a fair amount of erythema and there's scaling present. It's on both hands, and you can kind of see the patient's nails here. It's important when you're looking at dermatologic conditions to look at other areas, not just where you see the rash, but areas surrounding the rash, including nails, scalp, hair, these kinds of things. When we're trying to determine differential diagnoses, this can be very helpful. So what are the pertinent physical exam findings? So she has red, scaly, edematous rash, right? That's affecting both hands equally, and not just certain aspects of the hand, but the entire hand. And so what additional information would you like to ask or obtain from the patient so they can help you formulate your differential diagnoses? And so some of the questions that I think are important to ask are, has she recently changed any of her products? Lots of times you can have irritant reactions when you change your hand soap, for example. She washes her hands often. She's a waitress, so we have to consider that. Does she have a history of seasonal allergies? So this could be important to rule in or rule out certain conditions like atopic dermatitis. Okay, does she have any constitutional symptoms associated with the rash? So this is important because you may have a uh, medical condition that presents, an internal medical condition that presents as a dermatologic condition. And also you want to know about a stressful event, especially a major stressful event such as divorce or marriage or moving, because these can all aggravate dermatologic conditions. It makes every rash more severe. And also, how long has the rash been present? So she reported in the history that she has had the rash be problematic for at least 2 weeks, but how long has the rash actually been there? And so now, based on this information, what are your potential differential diagnoses for this rash? And so there are a few. And so there, you have to consider allergic contact dermatitis. And so we've asked her questions that can be related to that, right? Dyshidrosis, which is a form of eczema that causes blistering on the sides of the fingers, okay, and on the feet also, but right? And we have irritant dermatitis, atopic dermatitis, and tinea manuum. Now, tinea manuum is a fungus that affects the hands. And so, what is the preliminary diagnosis that you formulated for this rash based on the history, the images, and the additional questions that you're considering, even though we don't know what the patient answer to the questions are just yet? So just a preliminary diagnosis for this rash, and I'll give you a few seconds to consider. Okay, so the most popular choice was the contact dermatitis based on the answer choices that were provided. So how would each of the disorders listed in the previous question present? So let's take a look at that and see how might they present. And so atopic dermatitis is going to be a chronic rash. So when someone comes in and reports that they've had a rash since infancy or childhood, we want to start thinking about rashes that can be present that long. And so one of them is going to be atopic dermatitis. Another one that we might consider is psoriasis, but doesn't present like this. Okay. What other things might we consider? Contact dermatitis. This can happen anywhere on the skin. It usually has swelling and edema and vesicles associated with it. Okay. That tinea manuum, which is a red scaly rash, it can be itchy, but usually this will present on one hand only, and often the nails are affected. Okay, so dyshidrosis is another consideration. It's going to affect both hands and feet. Vesicles are present along sides of the fingers and the palmar plantar surfaces. Other body surfaces are generally not affected. Okay, so after the further questioning, the patient recalls that she's had an itchy rash in the folds of her arms and legs as a child, and that these rashes were treated with prescription creams, but she hasn't had any relapses in the rash, any new rashes for several years. She also recalls that her brother had a severe scaly rash as an infant. And so why is this important? Because people with atopic dermatitis or eczema often have a family history of another family member with similar rashes. Okay, so she denies any personal or family history of asthma or allergic rhinitis. Okay, so this could rule out some things. She has no Recent history of using any new household skin products. So it's important when we ask about new products because contact dermatitis may happen after we switch a product. And sometimes it may be difficult to determine what the cause is because a lot of times allergic contact dermatitis is going to be a delayed reaction. So you have exposure to something, let's say on Monday, and you have a reaction on Thursday. So you're looking for things that you did on that day or the day before, but it was actually something that you did on Monday. So based on all of this information, do you still think that your diagnosis is correct? What features of the history support your diagnosis? Now that you have a more complete history, do you still feel like your initial diagnosis is correct? Okay, and what findings on physical exam would help you to confirm your diagnosis? Now that we've talked about a few rashes that can present in a similar manner, there are distinguishing features, though, between them that can help you decide what is the most likely diagnosis. Okay, and if the patient had no history of atopy, or if a rash was more painful than pruritic, how would this change your diagnosis? And so sometimes we have to consider if a rash is painful, is there neurologic involvement like in shingles, or if it's very, very itchy, we might have to consider things like scabies, which might keep you up at night because it's so itchy. Scabies is a mite that can affect the skin. And so we just want to consider, those identifying factors that kind of describe the rash and through the patient history. Okay, so based on all the information that you have and the discussion of the differential diagnoses, what do you think this rash actually is? Is it the irritant contact or atopic derm, tinea manuum, dyshydrotic eczema, or allergic contact dermatitis? Okay, so the correct answer is atopic dermatitis. And so some of you might be surprised because, it could easily be an irritant contact dermatitis, perhaps, or an allergic contact dermatitis because she does have some factors in her history that could lead you down those roads, such as that she's a waitress, which probably means that she has her hands in water a lot, and also she might have exposure to chemicals at the restaurant that she might not be considering. So those are very good differential diagnoses, but the key factors in this case are that the rash was present when she was younger, and that her brother had a rash that was similar. And even though she denied any history of atopy, and when we say atopy, that means eczema as a child, asthma, or allergic rhinitis, they can, even though she denied some of those things, this case is still atopic dermatitis. But if a patient presents with itchy rash plus a history that supports the atopic triad that I just mentioned, then we're really going to lean towards the diagnosis of atopic derm. Okay, so do you have any questions? If you do, you can talk to me after class. I also am including some references on the clinical manifestations and diagnosis of atopic dermatitis, as well as a review of current treatment options for atopic dermatitis, because it's going to be one of the most common rashes that you're going to see in the primary care clinic, and so this is why I decided to use this particular diagnosis in a case study. So please ask any questions, and next week we're going to talk about some other very common dermatologic disorders that you're going to see in primary care.